Hello, good afternoon, everybody. We are very happy and very pleased to be here. And I would like to thank first the scientific committee, especially Dr. Mariano Sanz, that I met a long time ago in California, and Dr. Nitsan Bichacho. That's the reason why I'm here, why we are here, and also all MIS staff. I first want to say that we were really impressed by this organization. We were impressed last night. And what I was impressed about is not only the organization, but the details. And in life, everything is in details. I don't know if you remember that the food was good, which is not easy to have good food when you have 2,500 people. And also, the fish was warm, and the chocolate cake was great. And that's not based on luck. That was based on precise organization, and I'm sure that from the CEO to every single MIS employee in the world, during these past 5 or 6 months, everybody was thinking about how to create the success and how to try to avoid failure. And that's our presentation with Philippe. I've been working with Philippe for the past 25 years. He's our prosthodontist, I'm the surgeon. And because of this very intimate relationship, we came up with a protocol on immediate loading. And everybody knows that immediate loading is something now that is quite accepted as a predictable protocol. And whenever we want to see and speak about literature, we have to go to the literature review done by Dr. Esposito, and it's now part of evidence-based treatment, immediate loading. But if we look precisely in the new literature with Dr. Sanz, we can see that there are some problems. Even if we have some failures, we have very good high success rate, but we have some problems. And the goal of our organization is, we have been working with Philippe for a long, long time. We start immediate loading in the year 2000, and we publish all the time on this subject. But the goal is to show you how Monday morning, very precisely, how you could increase your success rate or perform in a very safe way. The goal is in life not only make things simple, but exactly also make them safe. If we look at this case, if we can come from this type of initial cases to this success rate, how we can go from this to this. This is quite important. And today, we have to look, and we saw some very nice presentation from Dr. Mashti about the literature, and what is important is to see what are the essential factors for long-term success rate. This is a key issue, and if we look at this case that we saw in our practice, we can say that this case, years later, probably there was some poor aging management, poor treatment planning. Today, we can move on, and with some new protocols, the goal is to be quite successful and also to be predictable. And for these two things, you need really to try to plan for failure. And we are using all these new diagnostic tools that were presented to you by all the lecturers this morning. And what are we using for ultimate therapeutic concept? This is, for us, the future. And we came up with our team. All the people are here. And I want also to thank my friend Serge Smukler, who is in the audience, that we came out with a clinical screening template. It is easy for myself, it is easy for the nurses, it is easy also to know where you go on the financial aspect. Okay, we have the risk factor, do we have any risk factor, where is the smile line, what type of biotype we have, the aesthetic demand, if the patient has a high aesthetic demand, you cross that before starting, this is clinical, then do we have an infection? Everybody spoke about the buccal thickness, the bone resorption, the transitional line, and the temporization. All these 10 very easy clinical parameters are crucial in order to establish where do we go. Are we going to extract some teeth, not extract some teeth? Are we going to work on the implants, the number of implants? Okay, a lot of people can say, okay, we put not a big number of implants, but we have to think about failure. Then are we going to use some bone augmentation? Are we going to use some soft tissue? We saw some fantastic presentation about soft tissue, and what type of temporization are we going to use? So all these concepts that you saw this morning, and we are going to summarize it in just very few slides, is we always think about the platform switching is important, and the biotype, the buccal bone thickness, and the implant neck design, and the conical connection. Each of these parameters, each of the concepts, they are not 100% success. We know that they showed earlier this morning, Professor Mithridade, that with the platform switching concept, it's not 100%, but it is just a plus. If you have thick tissue, it's a plus. If you have a conical connection, it's a plus. If you have the V-shaped design with no compression, it's a plus. So all these things are important to try to prevent poor future management. And we look at here, platform shifting. It doesn't work all the time, but it's important when you put some soft tissue. Eric Van Doren, so very nice cases, when you slide in some connective tissue, especially from the tuberosity, you can have great result. Bone thickness, we add almost all the time, we add some bone, especially in the fully edentulous patient. We use this very special neck implant design. We like the conical connection, and also we like here about the abutment that leaves us an important space, and we like when we can in the immediate loading business to put one abutment and that's it, and that allows us to have nice healing as it was shown by Dr. Franz Lambert. So our protocol, and it was designed by both of us, is we call it the 36-hour loading protocol. We see the patient usually on Thursday. It's our full surgical day. We do a lot of surgery under sedation, and Philippe is here, and we are going to show you this protocol, the 36-hour protocol. We're going to show it to you through 3 different cases and how we manage the patients, easy patient, more difficult patient, for this 36-hour immediate loading protocol. The first patient has a gingival file, has advanced bone, poor bone quality, and it's a real surgical challenge. So immediately we go to our clinical screen. Can we use the same protocol? We can see that there are poor bone quality that we're going to see here. So we are going to add more implant because of this very poor bone quality. We think of the clinical screening template. Risk factor, it's a high risk factor with the poor bone quality. The smile line is middle, the biotype is middle. There is a high aesthetic demand. It's endoperio, so we should be careful about removing all the teeth, removing all the infection. But we have a significant good bone thickness. We don't have that much bone resorption, and we have a visible transitional line, and Philippe is going to spend a lot of time on it. And we are going for immediate temporization. So we decided to extract the teeth. Some implants are going to be placed in healed side. We are going to fill the gap with bone, and we're going to do some lateral augmentation. And there is no soft tissue that is going to, is going to be done, no gingival graft, and it's going to be an immediate loading protocol.
Okay.
So,
to respect this protocol, we have to anticipate everything, so we have to prepare everything before the surgery. We have to collect some information and to transmit this information to the lab, and it's the reason why we have a roadmap. We need some impressions of the situation, the initial situation. We need to place the models in articulator. We need the technician lab need to have a complete set of photography, and we need to transmit the shade of the teeth, and also the implant project, how many implants and where they are going to be placed. With this, we asked the technician lab to do a customized impression tray, and also, and this is a prosthetic tip, we are going to give you some prosthetic tip during this lecture. And the first prosthetic tip is this special surgical guide which will be used to place correctly the implants, but also to register the vertical dimension. And this guide must have a special bite stop and also a complete palate.
And that helps us a lot. First, it's a normal surgical guide that we use. And this surgical guide has a very good stability because of the full palate stabilization that it allows us, after extracting all the teeth, to place that as a denture. We place oral implant. Most of the implant had primary stability at around 30 Newton, one even of them 25. So this is important to know. So we are trying to see what's going on here. We put the one-step abutment, the multi-unit abutment. We like a lot the multi-unit abutment. Then after putting the multi-unit abutment, we put the healing cap. Then we suture. And then after suturing, it's, again, the prosthetic time.
So we have to take the impression. And for the impression, we use impression copying. And we always splint the impression copying, because for us, the splint is the accuracy. And the impression is taken with material classic. It's a silicone. And the second step is to...
and what we have noticed with Philippe is that in order to be very quick, in order to have high success rate during surgery and during impression taking, we are very slow. We take a lot of time, and he's going to explain to you why.
And the next step is to register the vertical dimension. So we use this special surgical guide. We can place this firmly, the surgical guide, against the palate, and then we just have to fill the surgical guide with silicone and to ask the patient to bite gently to join the different bite stops.
And this is where you use the bite stops.
Okay. And this was the surgical guide. Now this is the base plate, and it becomes blue because we use an adhesive. And here we have register exactly the occlusion and the vertical dimension. And you can see here the different bite stop that allows us, at the lab to mount in the cast and to have in the same session the vertical dimension, the intermaxillary relation, and the job can be achieved by the dental lab. He can do the temporary prosthesis. This is an acrylic prosthesis with a metallic reinforcement. And we can place this temporary prosthesis the day after the surgery. We always have a control, radiographic control, to check the fit of the temporary prosthesis.
And we like, most of the time we're taking a Panorex, but we like to have periapical X-ray to be sure that everything is seated passively, and usually it is placed like a Friday afternoon at Philippe's office.
This is the healing period, and 6 months later we can take the final impression with the same technique, and we always check the accuracy of the model with a plaster key.
But here, if you say you have a problem, what kind of problem do you have here?
Here we have a buccally emergence, a slight buccally emergence of the screw channel, and we will see how we can treat that. Here we see we are going to perform a ceremometallic bridge in gold, so it's the reason why we use here the gold cylinder. But as you can see, there is a buccally emergent screw channel here. So in this case, we can use an angulated abutment, or it's the second tip I want to give you today, we can change the angulated.
I was drinking some water, sorry.
Yes, we can change the angulated sleeve at the lab. It's possible. But if you do that, you cannot use the conventional screwdriver. You have to use the angulated screwdriver, and with the same screw, we can change the axis.
So where did you buy this?
No, it's not. I asked my lab to manufacture this screwdriver because the angulated screwdriver is very short and we need a long shaft. So we did a laser welding. And then this is the wax maquette and framework fabrication.
So here we can see that everything comes into a better orientation of the sleeves.
The different channel axes are good now, and the framework is done classically in gold, and the ceramic can be built, and this is the final result with the control, the radiographic control, and the smile of the patient.
So here we have tried now to anticipate aging by using all the different tips, all the different research, all the different concepts in order to try, even if this is a lady that was over 75 years old, I would like to have to avoid any recession on implant, to avoid any peritonitis, to try to have thick tissue, thick bone. That was the goal on this patient. The second patient is a very young lady, around 40 years old. She had poor dentistry, and very quickly all her teeth were extracted. So she had advanced bone resorption. You can see very good bone quality. And we know that when we have patients like that have poor bone, poor available globally, but high bone density, it is a risky patient, as so the research. So we like to do these cases even. Most of the time we do that under sedation because these patients had a very poor history on dentistry and they're very frightened. And we have noticed that when they get nervous, we have a tendency to go a little bit too quickly. So we take all our time. We do you see how the bones is wide and dense? And here the risk is that the bone resorption is high, but it is very good bone quality. So when we have very, very good bone quality, we would like to have a very special implant preparation and taking the time to go through a lot of drills and even using the ultimate drills in order to really place the implant passively and to avoid compression. So it's heel side, and the goal is to have an all-and-4.
And here, unfortunately, we cannot use the surgical guide to register the vertical dimension. And we have to do the conventional vertical dimension assessment as we do with a complete removable denture. So we have to evaluate the vertical dimension and to mark the point on the skin before the surgery.
And then we go on with quite a classical surgery, but again, we take the time, we go through different drills. Sometimes you use 6 or 7 drills before placing the implant, and even with the V3 implant that were placed, we go very, very slowly. We checked the good orientation. We use the ultimate drill because the bone density is very, very good, and it is important to take the time and really not force. We don't torque it too much. We go to 40 Newton maximum. This is the way we like to do the surgery in this very dense bone. And the key to success is that the next day the patient shouldn't have any pain. When they start having some pain, it means that you compress the bone and perhaps you're going to have some failures. So this is a very, really important. You see, we don't use the key too much. We have placed our 4 implant. We have this multi-unit that we place. We place also the healing abutment, and then Philippe comes in.
It's a healing cap. And then we have to take the impression, and the impression is always taken with the same protocol. We always splint the impression abutment. No, impression abutment, and we don't like to use a lot of resin, so I use a wire, metallic wire, and a few quantity of resin. And then another tip is how to register the dimension, the vertical dimension in this situation. In fact, we use here the closed tray impression coping, not to take another impression, but just to block the occlusion at the right level. And if it's not high enough, we can add some raising on this impression coping, and then we can block the occlusion, and we just have to register with a silicone bite. Then we can give to the technician lab all the information, the impression, and the intermaxillary report. Here, you have to give these components to the lab, and you can see how the silicone bite for the fast cast positioning is used. Then, classically, the temporary prosthesis is done and placed 36 hours later.
And I want to add that really it takes Philippe most of the time less than half an hour to place the bridge in, because there is a very precise organization. We take the time. If the impression is not good, we take it again. We take some bite registration, and sometimes even under general anesthesia, it's difficult. So really, we have to be very, very slow and have good impression and register very nicely the vertical dimension.
So 3 months later, we can take the final impression. We always check the accuracy with a plaster key, and we are going to perform the final bridge here. We are not going to use a gold cylinder because we want to test other materials. So at the lab, they are going to fabricate the model, resin model with the wax first and then the resin. And the resin, the maquette, the final maquette is obtained with homothetic reduction. And this maquette can be scanned, and the file, STL file, is sent to the milling center, and then we can order different material. Here we have ordered 2 different frameworks, one framework in cobalt chrome alloy and one framework in zirconia. These 2 frameworks have been tested and controlled clinically and radiographically. Yeah. And then the ceramic is built on these 2 frameworks, and you can see the difference between the cobalt chrome and the zirconia. And the technician lab prefer working on the zirconia because he doesn't have to mask the grade effect of the metal. And here you have the 2 bridge, the cobalt chrome here and the zirconia here, and with the control, the radiographic control.
So according to the patient demand, according to your practice, you can now use even cobalt chrome framework. You can use a gold framework, zirconia, and of course titanium. So the last case I would like to present is a lady. She's about 55 years old. I've been following her in my practice, in the perio part of the practice for the past 15 years. She has a high smile line. She has flaring of the anterior teeth. And when I present this patient to Philippe, we said, okay, this is something very special. We have to take the time. We can see that here we have terminal peritonitis, flaring, a good amount of bone all over on this CT scan. And the major problem here, there is a high lip line, a high smile line, and this is very important because everything is visible. Everything is visible, so we have to be careful, and we have to really, when you do the decision tree template, we really have to follow the protocol in order to avoid failure. Why to avoid failure? Because we all see, coming in our practice, they come to see me and I say to Philippe, what can you do on this patient? He cannot do much. It's already too late, or he has to hide everything. Right. So one of the papers was written by our young team in our practice, Dr. Demirashvili and my son Kayvon, and what they did here, they tried really to precise what is the problem. So what is the problem, Philippe, here?
The problem is what we call the transition line. The transition line is the limit between the prosthesis and the soft tissue. And this transition line must be hidden by the lip. That's compulsory. And the problem is that sometimes we don't know where to place this transition line. Here, you have the smile line. And here, we know that over the smile line, you must place the implant 5 millimeters over the smile line. And sometimes we have to
cut the bone, and it's always difficult to cut the bone.
And this is very difficult to do that with a surgeon. It's very difficult to convince the surgeon to cut the bone like that, but if we don't do that, we obtain that kind of results.
Most of the time he's bugging me really, because we make up a very easy guide, which is a radiographic guide registering the smile line, and then when we have registered the smile line, we put some radio-opaque material. Then after we go to the CT scan, we can see very well the mark, and then the smile line is here, so we have to hide everything below it because the transition line is around that. So during the surgery, we transform this radiographic, and all the prosthetic components have to be hidden here. So during the surgery, we measure 5 millimeter, we remove everything which is on the top. Philippe tells me, don't extract the teeth.
Yes.
Why?
Before the surgery, we have to prepare something also, because we have to relocate the midline here. We have migration, we have diastemas, and we have to relocate the midline. So at the lab, we do what orthodontics do, and we do a setup, just cut the teeth and reposition the teeth in the right position. Then we do classically our customized impression tray, our surgical guide, and this is another tip. It's an indexed occlusion-based plate that we can use on the upper jaw. This indexed occlusion-based plate is indexed on the mandibular with 2 hooks to increase the stability, and
okay, sorry.
also there is a contact with the palate here. And now we go to the surgery.
So I don't extract the teeth. I use this now type of surgical guide just for bone removal before going to the real surgical guide. So I cut the bone up to this line, so we can hide the transitional line. So we just put some marks, remove the bone, then place all the implant into the bony envelope according to the surgical guide. Then we use these special implants, put the one-stage abutment, put the graft material, and suture.
And then we go back for the prosthesis. And before taking the impression, we are going to register the vertical dimension, because we do this registration onto the healing cap. So the first thing to check is we eliminate completely the contact between the healing cap and the base plate. And then we ask the patient to close. The palate come in contact with the palate of the patient. And then we just have to place some silicone, and we obtain here the base plate for the surgery. The impression is done classically with silicone, and we can transmit everything to the lab, and the temporary prosthesis can be done and delivery 36 hours.
So normal 36 temporary bridge, radiographic control, then we go on with the healing.
Yes, we have time. This is the healing, and then 6 months later, we decided to change the implants, not the implants, but the abutments on the cuspids, and we place angulated abutment. We take the impression, and we did also a maquette, resin for the cam.
The angles are corrected.
The STL file is sent to the milling center, and then we ask them to do a zirconia framework, and here you have the ceramization of this framework and the result, and different photo of this result, the smile of the patient.
So when we look at the smile line, we can see that we have fulfilled everything for this patient. She's quite happy about the result. We try to have all the latest technique to have good result, trying to see and try to anticipate aging, what's going to happen in 10 years. That's our goal. We don't know if we are going to succeed, but at least we're always thinking about that. So we have done with our team a significant number of immediate loading. We have 14 mandibles, 12 maxilla, our result, and on the implant number, as you can see, there is a significant implant number. We have 3 failures, high success rate. Again, we started this study only 2 years ago, even less than 2 years ago. So a lot of the cases are still in temporary bridge. So really, we have to be careful about that. So in conclusion, what is important here, we have to plan for failure, and we really have to think about all these crucial parameters. We always go clinically, then establish very precisely what we told you about this decisional tree template. And we have to acknowledge our team that help us throughout our practice, Philippe practice, my practice. And again, I would like to thank you a lot and telling you that, we have every year at the American Hospital in Paris, 5 live surgery. I just said 5 live surgery. And in this 5 live surgery, you have on 2 operating rooms, and that allows us to have good experience, nice surgery, nice prosthetic, and you don't lose your time, and at the same time, you can visit Paris. Thank you very much again for inviting us to this podium.
Good.